Craniofacial imaging in orthodontics. Good morning, everyone. Let me begin with a simple but critical idea. Without imaging, orthodontics would be like flying blind. When you look at a patient in your chair, you see teeth, lips, and smiles, but beneath that are hidden relationships between bones, soft tissues, and airways that cannot be seen clinically. Imaging allows us to detect problems before they are visible, document growth and development, measure skeletal and dental discrepancies, plan precise, individualized treatment. Orthodontics today has evolved from a mechanical craft of moving teeth into a biological and aesthetic science of managing the entire craniofacial complex. And imaging is at the heart of this evolution. Today's lecture will take us through 1. A historical journey of how imaging started. 2. The goals and purposes of imaging. 3. Conventional methods we still use. 4. Advanced soft tissue imaging. 5. The leap into digital and 3D with CBCT. 6. Emerging and future technologies like stereophotogrammetry. 7. The use of databases and digital ecosystems in diagnosis. By the end, you'll understand not just how to read these images, but why they change the way we think as orthodontists. 1. Historical evolution of imaging. Orthodontics as a specialty is relatively young, just about 120 years old. For most of its early history, diagnosis relied on photographs, study models, and the trained eye of the clinician. Then in 1931, Broadbent in the USA and Hofrath in Germany independently introduced standardized cephalometric radiography. For the first time, orthodontists could fix the patient's head in a cephalostat, capture a reproducible lateral radiograph, draw reference planes and angles, measure growth changes numerically. This was revolutionary. The clinical impact, cephalometry, allowed researchers like Steiner and Downs to create norms. We can now say, this patient's S&A angle is too large, meaning maxillary protrusion, or A and B is high, suggesting skeletal class 2. Number. But remember, these were 2D shadows of 3D anatomy. They could not show asymmetry. They suffered from magnification. Structures overlapped, creating interpretation errors. Still, cephalometry remains one of the most influential diagnostic tools in orthodontics. 2. Goals of imaging. Why do we take images? The purpose is not simply to see the teeth. It is to approximate the anatomic truth. That means reproducing reality as faithfully as possible. The goals are diagnosis, distinguish normal growth from abnormal; evaluation, measure relationships between jaws, teeth, and soft tissue; monitoring, track changes from growth or treatment; localization, find impacted, ectopic, or supernumerary teeth; planning, visualize surgery, orthodontics, and growth modification. Golden rule. Every radiograph must answer a clinical question. If you cannot state why you're taking an image, you probably don't need it. 3. Conventional 2D imaging. Cephalometric radiographs. These remain the workhorse of orthodontic diagnosis. Lateral cephs assess sagittal jaw relationships, vertical dimensions, incisor inclinations. Frontal cephs assess transverse asymmetries, skeletal balance. Example: in a class 3 patient, cephalometry quantifies whether the maxilla is retrusive, the mandible is protrusive, or both. Limitations: cannot reveal depth or true asymmetry. Left and right structures overlap. So cephs are essential but must be interpreted in context. Panoramic radiographs. A panoramic X-ray is like a wide-angle snapshot of the jaws. Advantages: survey of all teeth. Quick, low dose. Detect impactions, missing teeth, supernumeraries. Limitations: distortion and magnification. Not accurate for precise measurements. Example: you may see a canine impaction on a pano, but you won't know if it's buccal or palatal. That requires CBCT. Periapical radiographs. High-resolution films of individual teeth and roots. Excellent for root morphology, apical pathology, periodontal bone levels. 1 miles, but not practical to use routinely in orthodontics due to radiation load. Tomography. Conventional linear tomography was once used for TMJ imaging. Now, almost entirely replaced by CBCT. 4. Soft tissue imaging, MRI. Unlike X-rays, MRI uses no ionizing radiation. It is especially useful for temporomandibular joint evaluation. MRI shows disposition, normal or displaced, effusions, adhesions, inflammation of surrounding tissues, clinical relevance. Before planning surgery or orthodontic treatment in patients with joint pain, MRI helps us avoid worsening TMJ dysfunction. 5. Digital and 3D imaging. The digital transition. Digital radiography reduced exposure, allowed manipulation of images, and improved storage and sharing. But it still gave us 2D images. Cone beam CT. This was the revolution. Cone beam CT provides a true 3D dataset at lower radiation than medical CT. Key indications in orthodontics: impacted tooth localization, especially canines. Skeletal asymmetries. Airway evaluation. Orthognathic surgical planning. TMJ osseous assessment. Case: an impacted canine. A pano suggests location, but CBCT tells you exactly where. Buccal versus palatal, root resorption of neighboring teeth, and surgical access points. CBCT has shifted orthodontics from flat 2D estimation to volumetric certainty. 6. Emerging technologies, structured light and laser. Scanning, PA capture facial surface geometry. Stereophotogrammetry creates lifelike 3D facial images using multiple cameras. 3D. Superimposition. Number allows us to compare growth changes over time. Virtual treatment objectives, VTOs. TopTalk simulate orthodontic and surgical results for planning and patient communication. Sex sample, showing a Class 3 patient how their profile could look after mandibular setback, helps with treatment acceptance. 7. Databases and standardization. Digital imaging allows creation of large orthodontic databases. Advantages: standardized comparisons of cases. Growth prediction models using AI. Teaching resources for students. This is where orthodontics is heading: data-driven, evidence-based, and personalized. Conclusion. To wrap up, orthodontic imaging has traveled a long journey, from photographs and plaster models to cephalograms to CBCT, and now to digital 3D facial models. Key takeaways: Cephs and panoramics remain useful but limited. MRI is gold standard for TMJ soft tissue. CBCT is revolutionizing orthodontics, but must be prescribed judiciously. New technologies like stereophotogrammetry and VTOs are the future. Always remember, imaging is not just about teeth or bones. It's about the whole patient, their function, aesthetics, and psychology. Numbers guide us. Images guide us. But the face and the patient's quality of life is the final judge. Thank you.